Hello, my name is Kobe Ajayi, and I am a member of the 2020 MOM Board of Directors. I am also the founder and CEO of a non-profit organization that works to prevent preterm infant death while simultaneously closing gaps in maternal mental health in sub-Saharan Africa. Currently, I am pursuing a PhD in health education at Texas A&M University. It is such an honor to be introducing our first two speakers and the panel moderator for this final forum session. These speakers will shed light about supporting mothers and families from a global perspective. This is important for us in the US to enable us learn and leverage other avenues that can be incorporated into our national strategy for the optimal health and well-being of mothers and families. To this end, please allow me to welcome our very first speaker, who is Dr. Susana Castro Alcaraz. Dr. Susana is the Senior Medical Director of Women's Health, Optum Health Solutions, who will be sharing the America's Health Rankings data on US mental health and maternal infant health. Next is Rebecca Levin. Rebecca Levin is the Senior Maternal Health Advisor at the United States Agency for International Development. Rebecca will be sharing how the rest of the world is beginning to address maternal mental health in a broader way. After Rebecca's presentation, Dr. Vikram Patel, the Pershing Square Professor of Global Health at Harvard Medical School, will join the main stage to moderate a discussion with our two presenters and one other guest. With this, please allow me to say a warm welcome to everyone. Dr. Castro Alcaraz, I will now turn it over to you.
And in the meantime, we'll go ahead and have Rebecca join us, and we'll start with Rebecca and then turn it back to Susana. Thank you so much. Becca, welcome to the main stage. It's good to have you. And we're going to be pulling up your slides, and we'll need to get to those. That's in the middle of the deck here as we invite Susana to join us. All right, thank you, Josh.
No worries.
It takes a village, doesn't it?
It does.
To cover for each other in times of need. Very good.
Great.
Thanks, Rebecca. Welcome.
Absolutely. Thanks so much, Joy. Just say it's really an honor to be here today. I'm going to share a little bit with you about what the United States Agency for International Development is doing around the world in terms of maternal mental health. So for those of you who are not familiar with USAID or USAID, we are the world's premier international development agency. And for over 50 years, USAID's global health programs have helped save lives, protect people from vulnerable diseases, protect people most vulnerable to disease, and promote the stability of communities and nations while strengthening health systems and fostering innovation in partner countries around the world. Next slide, please. So I sit in the Office of Maternal and Child Health and Nutrition, which works to support and enable individuals to improve their own health and partner with communities and nations to strengthen their public health systems, to save lives and enable healthy and well-nourished women, children, and families to thrive. So when I joined USAID in 2017, after many years working with various international NGOs like Save the Children, I was really struck by the lack of focus on supporting women to not just survive, but also to thrive. And I think this was likely due to, we all know that mental health has long fallen behind physical health and attention, funding, and action. And that despite the World Health Organization including mental health as a fundamental aspect of overall health, mental health remains underfunded and often ignored in the face of more visible physical health concerns. In addition, health systems around the world have yet to respond to the burden of mental health, but the effect of mental health on both morbidity and mortality has become too important for us to ignore. And so also, like many of you, I myself have lived experience with maternal mental health and mental health more broadly, and know how critical a mom's physical and mental health is to an individual and a family's overall well-being. And so when I joined USAID, I set out on a mission to really explore the burden of maternal mental health conditions in USAID partner countries, to learn about ongoing programming in partner countries that we could help to support and advance, and to advocate that maternal mental health is not only an issue worthy of USAID's attention and investment, but that it should be prioritized amongst global and national maternal, newborn, and child health stakeholders around the world. So over the next several minutes, I am excited to share with you some of our learning over the last several years, updates on our efforts to prioritize mental health in global policy dialogue, as well as the efforts of the World Health Organization as the world's leading normative body for health recommendations and guidelines. So next slide, please. Since most of you are likely familiar with the US statistics, I wanted to share a quick snapshot of the burden of common perinatal mental health conditions in low and middle income countries, and to talk a little bit about mental health more broadly. So you may know that nearly 1 billion people around the world live with a mental health condition, and that people living with mental health conditions experience disproportionately higher rates of both disability and mortality. But what you may not know is that more than 80% of these individuals reside in low and middle income countries. Data shows that common perinatal mental disorders are the leading complication of pregnancy and childbirth around the world, and that approximately 1 in 5 women in low and middle income countries experience one or more common perinatal mental disorder. This average varies greatly across and within countries, which I will discuss on the next slide. It's also important to point out and to note, that these numbers have significantly increased since the start of the COVID-19 pandemic. So lastly, on this slide, this graphic on the left highlights some of the negative impacts of poor maternal mental health on women's health and quality of life, as well as overall health outcomes of newborns, infants, children, and adolescents. Next slide, please. So I would be remiss if I did not highlight the particularly significant role that social determinants play in maternal mental health in low and middle income countries. The graphic on the right, and I apologize, the writing is very small there, but it outlines the various social, economic, and political determinants that may contribute to the likelihood and severity of maternal mental health conditions. We know that most, if not all of these, are often beyond a woman's control. The multitude and gravity of many of these determinants in low and middle income countries contributes to much higher prevalence of common perinatal mental health conditions in many of these countries. For example, a systematic review of antenatal depression in sub-Saharan Africa found a staggering prevalence rate of 78% in Ethiopia, one of the world's poorest countries with a vast history of war and conflict, gender disparities, low literacy, alluding to the significant contribution that social determinants play in the prevalence of maternal mental health conditions. Next slide, please. Now I'd like to share a little bit about what USAID has been doing to elevate and advance maternal mental health on the global stage. So first, in 2021, after a multi-year effort, we published a comprehensive landscape analysis, which aimed to provide a broad understanding of the current literature on perinatal mental health in low and middle income countries, and to examine the relationship between perinatal mental health and maternal, newborn, child, and adolescent outcomes, as well as to identify promising interventions and implementation strategies. This publication includes more than 400 peer-reviewed and gray literature articles, includes findings from more than 60 key informant interviews, 2 focus group discussions, And lastly, includes a summary of relevant mental health policies in low and middle income countries that shape perinatal mental health programs. Then in September 2021, we co-hosted with the World Health Organization and the United Nations Population Fund, or UNFPA, a global virtual consultation to disseminate the findings of this landscape analysis and to bring together members from the maternal, newborn, child, and adolescent communities with the mental health communities to collaborate and to inform a path forward. This consultation focused on efforts to strengthen the research agenda, implementation approaches, and integration within health programs and services. We had over 1,500 participants representing 96 different countries. Participants included stakeholders from governments, ministries of health, civil society, healthcare workers, women and family members with lived experience, parent group members, and was the largest ever international meeting on maternal mental health, which we hope helped to raise awareness and hopefully investment in this space. We also have recently identified maternal mental health as a priority topic on the global Align MNH knowledge sharing and convening platform. Maternal mental health program implementation experiences and evidence from low middle income countries will be featured prominently in Align MNH's International Maternal Newborn Health Conference, which is to be held next May in Cape Town, South Africa. And lastly, stay tuned for an upcoming call to action opinion piece in BMC pregnancy and childbirth. Not quite sure of the publication date just yet. Next slide. So what's next? What's on the horizon? So we've got a lot of ongoing activities, one of which is we are funding the development of a client-centered theory of change in an effort to inform the most effective and efficient use of resources to address this complex issue of maternal mental health. We are also working with the World Health Organization to develop standardized global indicators that countries can use to track their progress on maternal mental health. And we know that there are still huge gaps in evidence on burden, social determinants, effective implementation strategies in different contexts and for different populations, such as youth and adolescents. So we're working to help inform a global learning agenda that we hope will influence research priorities for both donors and research institutions. We're also supporting the creation of a community of practice, as we believe that facilitating dialogue and learning across individuals and groups that may not currently be interacting is an accelerator for knowledge sharing and knowledge use. We are also hoping to do some implementation research of being able to demonstrate how to practically implement integrated maternal mental health services at scale in multiple different types of contexts. And lastly, two exciting resources that are soon to be forthcoming. On March 30th, the World Health Organization will launch their revised postnatal care guidelines, the first update since 2013. And among other things, these guidelines will include recommendations for screening and prevention interventions for maternal or for postpartum depression. And soon, WHO will be launching a perinatal mental health implementation guide, which will provide detailed step-by-step information with practical tools to address integration across different dimensions, including policy, planning, training, supervision, monitoring, evaluation, research, management, etc. Next slide, please. So my last two slides, I'm just going to show really quickly. They're really just meant to be a snapshot and library of various resources that are currently available and may be of interest to many of you. I believe these slides will be available on the Whova app afterwards. So please come back, take an opportunity to click on some of these links, which I also have in the next slide as well. As you'll see, there's a ton of international and global organizations and bodies that are working on maternal mental health, and I think a wonderful opportunity to learn. Next slide, last slide. So in closing, I just wanted to share my belief that there is a role for all of us to play to ensure that women, regardless of where they were born, have access to high quality, respectful care for both their physical and their mental well-being as a human right. And so thank you so much for this opportunity. And now I guess I will hand it back over to Susanna.
Good afternoon. Can you hear me and see me?
We can. Please proceed.
Okay, wonderful. I apologize for the technical difficulties. Thank you, Becca, and to all the organizers for this opportunity, and to all of you for taking the time to join me for today's presentation. I will spend this time taking you through the findings of the 2021 America's Health Rankings Health of Women and Children report. I'll present to you the recently published data and the insights around the health of women of reproductive age and children, populations that together make up approximately 40% of the US population. America's Health Rankings has collected and analyzed nearly 118 measures of health obtained from 35 unique data sources. Next slide. America's Health Ranking platform evaluates a comprehensive set of health, environmental, demographic, and socioeconomic data, and it aims to eliminate health challenges and successes, determine national and state health benchmarks, and enable policymakers, health officials, and community leaders to take action towards improving health. This platform provides state-by-state actionable, data-driven insights that stakeholders can use to affect change at both the state and the national levels, and spark dialogue around improving our nation's health and well-being. In addition to the annual report and the Health of Women and Children report that you're going to hear much more about today, we also have detailed analyses on the health of key populations in our country, including seniors and those who have served in the US Armed Forces, in addition to a deep dive into health disparities across the country. Next slide. As the COVID-19 pandemic has underscored the disproportionate health challenges faced by a variety of subpopulations, where possible, the platform breaks down state-level data by race and ethnicity, gender, age, education, and income to help public health experts better understand the factors affecting the health of various subpopulations. With over 58.2 million women between the ages of 18 to 44 and more than 73 million children under the age of 17 across the US today, it's imperative that we prioritize caring for these populations and understand the unique challenges that they face. Next slide. So now let's dive into the key findings in the Women and Children report. You can go to the next one. You can go to the next one. So the United States has seen sustained successes in reducing the rates of teen births across the country. Between 2013 and 19, the teen birth rate decreased 37% nationally. For females between the ages of 15 to 19 years, or nearly 172,000 births. All 50 states and the District of Columbia experienced decreases of 25% or more between 2013 and 2019. But large disparities remained by geography and by race and ethnicity. You can go to the next slide. The nation has unfortunately seen stagnation in the rates of low birth weight infants and low risk cesarean sections, and little progress in reducing persistent disparities between states and between racial and ethnic groups. In 2019, 8.3% of infants were born with low birth weights, which we define as less than 5 pounds, 8 ounces. Affecting over 300,000 infants who face an increased risk of a variety of short and long-term health complications as a result. Low birth weights among infants born to Black mothers was 2.1 times higher than among infants born to white mothers. And a similar lack of progress is evident in the rate of low-risk births delivered by cesarean. Despite targeted public health efforts aimed at reducing the rate of low-risk cesarean deliveries, it only decreased by 2% between 2014 and 2019. And the proportion of low-risk cesarean deliveries remains consistently higher among Black women than white or Hispanic women. Next slide. The US has the highest maternal mortality rate of all developed countries, and it is the only industrialized nation with a rising rate. American maternal morbidity rates are also rising, with Black mothers facing the greatest challenge. In 2018 and 2019, maternal mortality increased 16% nationally. Maternal mortality was 3.3 times higher among Black women than Hispanic mothers. And 3 states had the greatest increases in maternal mortality rates: Florida, which had a 70% increase, followed by Georgia, up 23%, and then Indiana, up 16%. Next slide. Even during the time leading up to the pandemic, behavioral health challenges increased for both women and children. Women experienced high and rising rates of drug deaths and reported frequent mental distress, and children faced great increases in teen suicide and anxiety. Deaths due to drug injury increased among women across the nation. Between 2014 and 16 compared to 2017 to 19, there was a 24% increase in deaths for females between the ages of 20 to 44 years of age, or 33,000 women. This increase was widespread across states and racial and ethnic groups. In addition, in 2018 to 2019, 18.1% of women between the ages of 18 to 44 years reported their mental health was not good for 14 or more days in the past 30 days. This is equivalent to roughly 10.2 million women. Disparities in the prevalence of frequent mental distress exist by state, race, ethnicity, and income level. Frequent mental distress was 2.1 times higher among women in West Virginia than in Hawaii, the states with the highest and the lowest prevalence, respectively. 2.4 times higher among multiracial women than among Asian women, and 2.4 times higher in women with a household income of less than $25,000 per year compared to women with a household income of $75,000 or more annually. Next slide. Significant increases in teen suicide and childhood anxiety as well, unfortunately, with rates increasing across all states, races, and ethnicity. Overall, the teen suicide rate increased 26% from 2014 to 16 compared to 2017 to 19 for adolescents between the ages of 15 to 19 years. In this period leading up to and in the early stages of the pandemic, anxiety was widespread and rising among children. In 2019 to 2020, 9.1% of children between the ages of 3 and 17 years, so nearly 5.6 million children, had anxiety problems, a 21% increase since 2017 to 18. Next slide. Now turning to behavioral and mental health, why disparities exist by gender, educational attainment, race, and ethnicity, with worsening rates for many subpopulations. In 2017 to 19, adults with less than a high school education had a 123% higher rate of frequent mental distress and 46% higher rate of depression compared to college graduate adults. On the other hand, excessive drinking was highest among those with some college or a college degree. And females had a 70% higher rate of depression and 38% higher rate of frequent mental distress compared to males. Next slide. Turning now to the Health Disparities Report, even prior to the COVID-19 pandemic, disparities in household food insecurity were wide. Food insecurity rates increased 39% for American Indian, Alaska Native households. Disparities in food insecurity were also significant by education. Since 2003 to 2007 time period, food insecurity rates increased 15% in households headed by those with less than a high school education and 19% in households headed by college graduates. Before the COVID-19 pandemic, some progress was made in reducing the rate of severe housing problems. Despite progress in reducing the percentage of households facing severe housing problems, households headed by Hispanic, Black, and American Indian or Alaskan Natives individuals had a rate of severe housing problems roughly 2 times higher than households headed by white individuals. This report also documents a strong link between educational attainment and health, demonstrated across several measures where adults who have attained higher levels of education have better health. Notably, adults lacking a high school education face the greatest social, economic, and health challenges across the nation. The report found those with less than a high school education face substantial barriers to healthcare access as well. Compared to college graduates, the uninsured rate for individuals with less than a high school education is nearly 3 times higher. And the rate of avoiding care due to cost was also 3 times higher for those with less than a high school education when compared to those of college graduates. Key health outcomes were also correlated with educational attainment. Those with less than a high school education faced poorer health outcomes. Next slide. As the COVID-19 pandemic continues to impact communities across the nation, it's critical that we maintain a focus on the health of women and children in particular, and the unique challenges that they face. The 2021 America's Health Ranking Report offers insights into the health of each state and aims to spark conversations among policymakers, health experts, and other public health leaders to improve our nation's health and health outcomes across all communities. All the information discussed in today's presentation is available on our website. You can go to the next slide. And here users can compare and contrast a specific health measure by year and by subpopulation where available to help visualize trends over time and variations by group. I encourage you all to visit americashealthranking.org, where you can browse the full report and access the entire suite of data and resources and explore our online interactive tools. Thank you for taking the time to listen to today's presentation, and I believe I'm going to turn it over now to Dr. Patel, who will lead the panel discussion.
Well, thank you, Susanna. If I may use your first name to make it more informal, and also I'd invite Becca and Sean to show their videos as well now. So we're in for about I think a 40-minute opportunity to actually interact with each other. And I want to make this a really interactive event so that we are able to ask questions to each other freely and interrogate some of the themes that have been raised by both of you in your presentations. But first, before I do that, I'm going to invite Sean to introduce himself as one of the panelists who's joining us today. Sean.
Yeah, thanks, Vikram, so much. I'm Sean Mayberry. I'm the CEO and founder of an organization called Strong Minds. Just quickly, what Strong Minds is, we have the mission to improve the mental health of women of all ages in Africa. I founded Strong Minds in 2013 in Uganda. We're now in Uganda and Zambia. And we use a simple form of group talk therapy to help women overcome depression and to prevent future episodes. We've treated now about 150,000 women in Uganda and Zambia, and look forward to treating 300,000 women in the next 3 years. Thanks, Vikram.
Thank you, Sean. We'll turn back to you, circle back to you, in a moment after we've had a few questions for Susanna and then Becca on their presentations. Let's just remind ourselves that this session is not just about America's health rankings, which is what I'm going to turn to first, but also what can America learn from parts of the world, such as the ones that Sean works in, as well as what Becca has referred to. But let me start firstly with you, Susanna. In your presentation, I took away a number of really, fairly worrying findings. The first is, of course, that the US has the worst maternal health, more general maternal health metrics in all the OECD countries, if I remember that slide correctly. The second is that there are gigantic disparities, and those disparities cut across many different structural strata, income, race, etc. And then those also then translate more specifically to the domain of mental health, but I'm going to come to that in a moment. Just to hear your thoughts, what do you think are the main drivers why the US, in spite of spending more money per capita on healthcare than any other country in the world, has the worst metrics compared to its peers in the developed world?
Yeah, that's such a great question, one that I have as well. And And there's so much to talk about. So as you heard, the maternal mortality rate has been steadily increasing and has reached an all-time alarming high rate, with considerable geographic, racial, ethnic disparities. And we rank last in terms of maternal mortality over the industrialized countries. It's estimated that as many as 2/3 of maternal deaths are likely preventable. And yesterday we heard a lot about structural racism and how that can be one of the root causes of racial, ethnic inequalities and maternal experiences. One important driver of inequalities in maternal health is distrust in the health system. As a result of both historic as well as current discrimination, which can lead to fragmented and lower prenatal care utilization and adherence to treatment plans during and after pregnancy. And I think this was illustrated in the film that we watched yesterday, Toxic: A Black Woman's Story. Another important driver of inequalities is the variation in hospital level quality of care. And there is substantial variation within hospitals. This can vary greatly depending on geography and the hospital's ability to handle maternal emergencies and complications. And there are many things that need to be done to standardize and improve safety and quality across the board to really help reduce adverse maternal outcomes in the hospital setting. We need to improve team communication, team training. We need to include and embed safety huddles and checklists into our daily routines and really try and support a culture of safety that encourages open communication among all team members that's transparent and non-punitive. We need to train on implicit bias across all healthcare workers and really try to sensitize individuals to the role that implicit bias may play in their daily interactions with patients. And these include stereotyping and prejudices that affect our behaviors that we may not be aware of. We also need to include evidence-based safety bundles and toolkits that manage some of the more common obstetric complications that we're likely to encounter. And we need to require review committees to examine root cause analyses and really try and determine why there was a maternal death and institute safety measures and protocols and share this knowledge to really help prevent these causes. We need policies to address racism and social determinants of health to improve quality of care and healthcare experiences for all moms. We need a collaborative approach to help mothers to include utilizing community-based organizations, really tap into those resources and any resource available to them to help them, throughout their pregnancy. There are care delivery models that are being evaluated now as strategies to try to close some of these disparities that have been touched upon, such as the use of doulas. There's group antenatal care, and then also postpartum home visits are a really good way to have an integrated interdisciplinary health team visit moms postpartum, and these have shown some promising results. Multidisciplinary care should begin preconception before moms actually even get pregnant. And it should start with risk assessments and evaluations with strategies aimed at identifying high-risk conditions early and trying to reduce some of these modifiable chronic conditions, such as obesity, hypertension, and diabetes in women of reproductive age to really help reduce that incidence of cardiovascular disease and major adverse events that we know we have. And these are events that are way too frequent. And we know that this prevalence of chronic medical conditions is also increasing in the United States. Then we have undetected and untreated mental health conditions, as you've heard a lot about in the last couple of days. Substance use, intimate partner violence, these are all common risk factors for maternal mortality, really reinforcing the importance of screening and providing interdisciplinary perinatal management. We need to, really think about and address the impact of mental health and the effect of stress and depression and anxiety that that oftentimes goes overlooked. And we've heard how important these are, in the past few days to really ensure that these women are being well supported, whether it's with families or doula support, group prenatal care. We need to make sure that they're eating and that they're getting enough sleep and that they're getting physical exercise. And these are topics we really didn't get a chance to talk about, also covered in the American Health Rankings report. We also need to do a better job of providing patients and their families with education. Specifically, healthcare providers have to impart knowledge about early warning signs, when to seek care, and provide postpartum care and home visits after delivery with either a nurse or a midwife, as this has been shown to improve mental health. It's been shown to improve breastfeeding outcomes and also reduce healthcare costs. I'm not going to talk about expanding reimbursement for postpartum care for at least a year of age, until a year of age, and the importance of doula services. I think that we heard this firsthand experience from Amy Chen earlier today on how important it was for her experience and how costly it was as well. Additionally, we can improve access to care and support by increasing utilization of midwives rather than utilizing OBs for so much of the care that we provide, especially for those low-risk pregnancies. Other countries with higher use of midwives in their workforce have shown a reduction in maternal mortality and morbidity. They've shown reductions in preterm births, stillbirths, C-sections, and overall improved patient satisfaction as well. And then just lastly, at state and national levels, we need legislation and funding for important bills like the Moms Matter Act that you heard about earlier today, and professional organizations and stakeholders really to come together and collaborate and form partnerships and work together to really implement thoughtful quality improvement initiatives and expand access to address these preventable deaths that are occurring every day.
Well, thanks, Susanna. This brings me to a very nice segue to you, Becca. One of the things I took away from your presentation was how much evidence has been generated in low-resource countries that have, by comparison with the US, almost nothing, let's be honest. I mean, for example, maternal mental health services for most women in most parts of the world are non-existent. They're only on paper. And so I was impressed by how much evidence has been collated, enough to produce all those different reports that you mentioned. So I really have two questions for you. The first question is, why has none of it actually come to fruition? Why do we only have reports? On the ground, I live and work in India. I don't see any shred of maternal mental health care. So what is it that stops at the report stage, and how can we actually shift the needle of actually going beyond writing reports? And secondly, what do you think might be the implications for this knowledge for the US? And of course, let's remind ourselves that that's a key theme of this particular session, is what can the US learn from the rest of the world? Becca.
Thanks so much, Dr. Patel. So I think to your first question, there's, in my mind, two things in particular that are preventing the sort of scale up, if you will, or the implementation of much of this evidence and research. One is, quite frankly, stigma and discrimination, that mental health and the mental illness, that term is has a lot of stigma and associated sort of discrimination in many low and middle income countries. And in many places, people who are identified as having mental illness are actually institutionalized, sent to prison, et cetera. And so it's not a topic that's being discussed openly. I think we're starting to see a shift and a change in that, in part thanks to the COVID-19 pandemic. One of the few, I think, silver linings was being able to bring to the forefront this issue around mental health and the impact that mental health has on a society's ability to be productive and prosperous at large, and how important mental health is to physical health and well-being. But I really think that in order for us to see maternal mental health and mental health services more broadly being implemented, we need to address the issues around stigma and discrimination. That's the first. The second is around limited resources and trying to prioritize where to invest those limited resources. In many of the countries where USAID partners, our partner governments and ministries of health have really difficult decisions that they have to make about where to invest those limited resources that they have. And what we've seen is that physical health, which perhaps because physical health can be much more visible in nature or is less stigmatized, has been talked about for much greater period of time and much easier, is prioritized over mental health and mental well-being. That sort of also global drive to reduce mortality and the reduction of morbidity has not yet caught up to that. And so I think there's a lot of pressure for resources to be invested where there's going to be the most lives saved, if you will. Just with that said, actually more people die globally of suicide than of malaria every year. So, you know, there's a lot of advocacy and advocates again now in the global mental health arena that are talking about it actually is a good economic investment and cost effective to invest in the mental health of your population. So that was, I think, the answer to your first question. And then your second question around what can the US learn from countries overseas? And I think maybe linked to your question to Susanna around, we are a very wealthy nation, and yet we have the highest maternal mortality in the OECD countries. We have abysmal mental health care here in the US. So what we can learn from small scale efforts in many of the countries that USAID works in is how to actually provide effective mental health services at low cost and with minimal resources through utilizing non-specialized medical professionals, peer volunteers, community health workers. There's a lot that can be done, as you know, with individuals who can be trained to provide mental health services. I think there's oftentimes a misunderstanding that when we talk about mental health, that we're talking always about pharmacology or that we're talking about specialized care through psychologists or psychiatrists, when in fact we know that most women and for maternal mental health at least, that screening, prevention, and treatment and management services can be provided by non-specialized healthcare workers. And we have lots of evidence to show that in low middle income countries that I think we can adapt for here in the US as well.
Thanks, Becca. You know, I'm glad you mentioned that. You know, that's certainly been an area that I have been very passionate about. And maybe for your you know, for the audience, I wanted to just you know, just summarize some of that evidence. Essentially, the evidence that Becca you're referring to, which has really you know, been a driver for all these different reports, has been the evidence from randomized control trials that has shown that appropriately trained and supervised frontline workers, and they come from very different backgrounds, community health workers, peers, that is mothers themselves, and a variety of other kinds of workers who share one thing in common, that they don't have mental health professional training, that with appropriately designed training and supervision and appropriately designed psychological interventions that almost always have a social component as well, you can actually help a significant chunk of women who are depressed recover. And this is far better than whatever usual care is available in all of these countries. This is a dramatic piece of evidence, by the way. You know, it's so dramatic that it's now found its way into all these reports. There's no longer a question about whether or not community health workers with the right training and the right tools, the treatment itself, can effectively treat depression, both in the general population, but also in mothers. But it's a question really now of how do you scale up? In fact, I think it's a pointless exercise to do more trials of this particular approach, and our energies really need to shift towards scale up. Now, it's interesting you spoke about pharmacology. I actually think if psychotherapy was a drug, it would be immediately available in developing countries. I actually think that this is the elephant in the room. I think stigma is important, but actually stigma would vanish if it was a pill. I think the issue really is there is no commercial value in psychological interventions. There is no company backing it. And as long as these interventions don't have a champion in the government or in development agencies, to actually produce scalable pathways to actually transform the evidence into practice, they will always remain stuck in reports. Consider the fact that even in the US, which has more psychologists per capita than any other country in the world, about 80% of people with depression don't receive psychotherapy, even though the vast majority of them want psychotherapy. So I actually think this is a structural issue, not only stigma, but actually about the way resources are utilized and the kind of methods we think about scaling up psychological therapies that are always going to need the backing of the state or other sustainable sources of funding, rather than relying on pharmaceutical companies, which, drugs don't need any backing. They're going to always be out there because there's already a commercial motive to actually sell them. So I think that in terms of the application of this evidence in the US, many of your audience may be interested to know that PCORI, the big federal funder, has just funded, or not just, a couple of years ago, funded the largest trial of task sharing for maternal depression in North America, which will involve 1,300 mothers in 3 sites in North America, a chunk of whom are getting a brief treatment that was designed in India, in fact, a behavioral activation treatment that was adapted for mothers, which will be delivered by nurses and midwives. In a sense, that's task sharing in the North American context. And the other half will get it from a psychologist and a psychiatrist. And the question is really a non-inferiority question. But it's an interesting one, because it suggests that federal funders are now actually saying this science is compelling enough to now evaluate it in the US. But the difference, of course, is the US comparator arm is not usual care, which in most parts of the world is no care, but actually the highest standard of care, which is presumed highest standard of care, which is the mental health professional. And the other example I wanted to make of what I call reverse engineering these kinds of approaches to the US is addressing the barrier of training. Actually, I think this is another huge barrier, Becca. The barrier of having 19th century models of training where an expert brings people into a workshop in person. Of course, the last 2 years have completely transformed whole notions of training, but it is the dominant form until COVID came along. And then you've got the expert who will sit and mimic what a trial does for quality assessment and supervision. Well, of course, this is not a huge issue about scaling up. India alone has 2 million frontline workers. Imagine if you had to do workshop-based training to scale things up. I mean, you'll be taking 100 years to actually train them. So Empower is this new platform that we've built, and it is actually using digital tools for learning, for mastering and delivering psychological treatments at scale. But the reverse engineering piece is this. Last year, I say we because I lead it from Harvard Medical School, won a big prize in Texas to bring brief depression treatments into Texas through community health workers by using the Empower platform. And we are also now working on adapting this depression treatment for mothers using the same treatment that is being used in the PCORI trial. So there is movement. I think there is an appetite in the US for transformation. And I think one way to do that is to actually get scalable systems of training and supervision in place so that you can train at a very short time vast numbers of workers, because you don't actually need the expert and you don't need to be in person. And so this to me is one of the potential transformative avenues to actually bring things to the US and indeed to scale up in developing countries as well. In fact, we're doing the same work in India, where we now are about to finish training 2,000 ASHAs, which is the community health work in India, to treat depression. But I think this brings me nicely to Sean, because Sean has been leading through the NGO that he mentioned in his introduction, depression care for women in Uganda. And Sean, what I really wanted to ask you is, I believe you have plans to bring this model to the US. So I'm sure we're all really interested to hear more about what your plans are and how you're going to implement these.
Yeah, happy to. Thanks so much. I wanted to make some comments on the great discussion that we're having. Just as somebody who's been leading Strong Minds for almost a decade in Africa, and having worked in Africa for another 10 years on top of that in maternal health and malaria and all sorts of kind of health interventions. I don't really believe it's stigma that's holding us back on mental health. For me, it's really about resources. I agree there's strong stigma on certain mental illnesses like schizophrenia, but we don't really see stigma towards depression. Particularly in Uganda and Zambia, most people don't understand what depression is. So there's not really a stigma about something they don't understand. For us, it's really just about resources. We've been at this almost 10 years. As I mentioned in my opening, we've treated 150,000 people. The only thing holding us back from treating 500,000, 1 million, 5 million is resources. When you look at total mental health funding into Africa in the last 10 years, it's less than 1% of total mental health, it's less than 1% of all health funding. If we had the resources, we could reach so many more. We work so closely with ministries of health in Uganda and Zambia, and it's just about how do we get more resources to do this. We're training community health workers. We have their support, but again, there's just, as we like to say, there's just no gas in the tank of the car for us to go much further. So more resources on the problem in the developing world, I think, would go a long way. When you talk about, I so agree with what Vikram was saying about there's just simple forms of training. The old days of the trainer coming in and sitting in the room. For us in Strong Minds, we are training people now just on very analog phones, not even mobile phones, where we're calling hundreds of kilometers away and training them in northern Uganda, where we're working in settlements of refugees and really finding huge success. And it goes to the same point that Vikram was making as well in terms of just task shifting. The key of Strong Minds reaching so many people in Africa and Vikram's efforts in India, it's just about having simple models that we can really allow peers to treat peers. It's taking away the requirement that we need doctors and nurses who are so difficult to train in mental health and limiting that access. So really making it available at the peer-to-peer level will really just expand it. When you think about what we've done in Africa, Vikram, we're moving into the United States right now. We'd be launching actually in Newark, New Jersey, a very difficult kind of neighborhood. We'd mostly be using our same model, which is a very simple form of group talk therapy that was proven in an RCT in Uganda years back. It's just such a challenge, though. It's funny to say this, but it's so easy to deliver mental health services in Uganda and Zambia. It's much easier to do it there than I'm finding here in the United States in terms of regulations, licensure. It's just incredibly difficult, in terms of what we've already reached there. We see ourselves going much more slowly here in the United States, which is just a huge learning. And I think we just have so much more that we can learn from models that we're doing in Africa or India or elsewhere, and how we can really speed up the access. When you look at the need for mental health access in the United States, when I'm writing proposals about our launch in the US, it just is so eerily similar to when I'm writing proposals for why we need mental health services in Uganda, which is that there's just such limited access for those most in need.
Well, thank you, Sean. Well, all good wishes to you and for succeeding. I do remember a few years earlier, I had the privilege of being with the then First Lady of New York City at the launch of the Friendship Bench in Brooklyn, and unfortunately didn't survive either.
No.
And that's of course has its own complex set of reasons, but the fact that there is no more real. The benches are still there, and there's I think still certain
they are
who sort of use those in a kind of in a friendly way, which is I think what a lot of this is about. But unfortunately, the whole kind of support structure that was there for training has currently at least gone into deep freeze. But I hope that you are able to push the envelope. Certainly in my own work, one key strategy I've used is getting the buy-in of the guilds, because the guilds are very powerful in America, and I think that's what you and I will have found are non-existent in the developing world. The guilds are present, but they don't have the same heft that you see in the US. The guilds are the primary reason for so long the US never got universal health coverage, honestly. And I think the guilds are also going to be very, very hostile towards any expansion into their territory. So in my work, I just reached out to the American Psychological Association, and currently the CEO there is a visionary man, Arthur Evans, and and he completely saw the whole point. It was saw it as an example of how psychological science can benefit Americans rather than the guild being purely about speaking to the interests of its members. And so I would encourage you to reach out to the APA. I think the leadership there is very receptive to what they call population mental health, and this is a particular strategy that they're very excited about. So please do go ahead. I think you'll probably get a very warm hearing and possibly more. So, I think these are the kind of models that it seems to me we should be thinking about to bring to America, essentially community-focused delivery of mental health services. To me, that's an extension of what Susanna mentioned as a reason why maternal mortality is so much higher in the US, which is the over-reliance on highly medicalized professionals. And I think you spoke to the issue of using midwives, which for me is task sharing. Task sharing is not only about going to a community health worker, it's about not always medicalizing every health encounter and relying on highly specialized MDs, but instead thinking of nurses, midwives, even primary care practitioners for many other kinds of health problems, and of course community health workers and other peer support workers and so on. So I think task sharing outside the mental health care system must surely be the single most important strategy to improve equitable access to mental health services for the most common maternal mental health problem, which is mood and anxiety conditions. Of course, psychosis is rare, very severe, and I think perhaps there might be other models that are needed. But for the most common perinatal mental health problems, I'd leave it to all of you to sort of think about task sharing as the foundation, and that using digital models for training and supervision offer the one opportunity for a rapid scale up of this knowledge into practice. Let me throw it open to all three of you now. Any questions that any of you might have for the others on this panel? I'd welcome them, but also just ask you for any closing remarks. We have about another 5 minutes before we close. I just got a message on that. So any closing remarks that any of you might have? I'm particularly thinking about, in your own work, how do you see yourself actually building on this idea of improving equitable access to mental health care? Maybe I'll start with you, Susanna.
Yeah, sure. So, I mean, I guess what strikes me the most is, what Sean mentioned earlier. He doesn't have resources, and in the U.S. we spend, as you mentioned, more on healthcare than any other country, and yet we have the worst outcomes. And I think that we have an opportunity here. We have to learn about alternative approaches, as has been mentioned, from other countries who don't have those resources and are making do and are developing models that can be really useful and effective, and likely to be more effective than what we're currently doing. I think we do need to invest in our primary care systems. I think that we need to make sure that our systems are equitable in all of our communities. And I think that we do need to also invest in social services, as we know that social determinants of health are so important and do impact the health that our mothers and our children are getting.
Yeah, well, thank you, Susanna. I can't agree more with your remarks there. Becca.
Yeah, thanks, Dr. Patel. I guess from my perspective, working in maternal health within the broader maternal newborn child health global arena, being honest about the fact that sometimes in order to get resources and attention to a maternal health issue, we have to use newborns and children as the Trojan horse. And so for me, it's also been talking about that maternal mental health not only impacts women and our own well-being, but also those of our newborns and our children, and can have intergenerational impacts. And so for me, I think thinking about how to broaden the coalition of people that are investing and interested in this within USAID. We're now thinking about maternal mental health as an issue that's critical for newborn health and child health and nutritional outcomes, and as fundamental to primary health care. So for me, I think, again, advocating that mental health is equal to physical health, and making sure that when we're talking about health, we're not just talking about physical health.
Well, Becca, I think that's a very, very important strategy. I don't, I know that sometimes people say, well, we shouldn't distract from the real goal of our mission, which is maternal mental health. But in fact, honestly, I do think it's a very, very strategic to actually link maternal mental health with other priority areas like you've done. And I think child nutrition and development is absolutely a great example. And I believe that that is, in fact, also the most likely way to integrate and scale up mental health care for mothers. It's not going to happen through a vertical system, never will. I think it's going to have to happen through existing delivery channels. And the one delivery channel that I have seen has grown dramatically in the last decade is the focus on early child development, expanding the child nutrition delivery channel to development. And of course, we all know the strong evidence that connects maternal mental health with child development in a bi-directional way. And I think, therefore, this is a wonderful opportunity that you describe. I had one more question about the point you made earlier, there's no champions. And I wondered, I'm always inspired by the story of HIV/AIDS, that story being that people with a lived experience of HIV/AIDS were the ones who actually got the real, the traction that we see today in terms of, the Global Fund, et cetera, did not happen because we had randomized controlled trials alone. We had it because we had those trials that demonstrated effective interventions and the advocacy of people living with HIV/AIDS that, forced, decision makers to take a moral position on this issue. So I wondered, to what extent are you seeing coalitions of women who have themselves lived with mental health difficulties, lobbying their local representatives?
All over the place. It's incredible and incredibly inspiring. During the technical consultation I referenced before, we had one woman that comes to mind is a woman named Pascaline Njau from Kenya, who was formerly a lawyer and experienced severe postpartum depression and is now a national advocate and influential in policymaking in Kenya. And she's brought together an incredible coalition of women with lived experience. And they've been really, really effective at advocating and lobbying for greater policy and services. So it's happening all over the world. And I think, again, just from my own experience, it's sort of 5 years now in at USAID, and we're finally starting to have people talk about mental health and maternal mental health more broadly. You just have to keep bringing it up, the talking points over and over and over again. And eventually people, I think, are going to catch on.
Sean, your closing thoughts.
Yeah, I love so much of what you were saying, Becca, in terms of, and that question, Vikram, in terms of creating the global movement, right? It's not there yet, but I see it as well, at the community level. One of my dreams, which would make me so happy, is when we actually see the Global Fund for Mental Health created, right? And we actually have funds and to get that going. And another comment I think you made, Becca, just about creating more awareness, for example, in your case in USAID. At the end of the day, we have the solutions to many mental illnesses, particularly depression, which is the number one. It's just a matter of us getting the word out to people that we have the solution. Let's just get it out there. So, sometimes I can be accused of being overly pragmatic, but that's what I'm working on here. And for me, that's how we'll make the world a better place, is just getting these simple solutions out so more people more moms can have better mental health.
Absolutely, Sean. I just want to amplify that. And I want to say that, when you say, when you emphasize we have the solutions, you're absolutely right. Those solutions, though, will need the support and backing of non-commercial entities, because the solutions do not lie in the commercial sector. They lie in psychosocial interventions. And I think those solutions also point to the fact that mental health problems lie on a dimension, and a one-size-fits-all that has dominated our thinking. The idea that you diagnose people irrespective of their context, their culture, their demographic characteristics, or the severity of their condition, and then you follow some, almost mindless algorithm for treatment. We've got to move beyond that, and we've got to recognize that a large number of those who we call mentally ill are people who have distress states that can respond very well to targeted interventions that are psychosocial in nature and are delivered in their communities by people they identify with. And that really that to me is the future of mental health care everywhere, including here in the US. Well, thank you, all three of you, for this terrific panel and discussion. And I think I'm just going to say thanks to you from the organizers, and I'm going to hand now back to Joy.
Thank you so much, Dr. Patel. we're almost done here. Thank goodness, tripping over my words. But what an incredible discussion. We appreciate your wisdom and your experience in other countries so much. We are going to be blogging about what we heard today on this panel, the last panel, and the panel before to help make sense of all these great ideas and strategies. And we'll be sharing that blog next week. What we're going to do now, like we always do, is to put up the Poll Everywhere instructions. There you go. pollev.com/2020mom. Go to a web browser, type in the word or phrase with an underscore if you use multiple words that most resonated with you from this discussion. And we'll pop up those words here in just a moment. And I can tell you, I was very excited and not surprised to hear the value of community health workers and peer support specialists, or even those without formalized certifications as serving mothers here in the US. So Sean and Dr. Patel, it'll be really fun to brainstorm more with you about how we all might be able to scale up that work. Community, powerful with the heart. Haven't seen an emoji yet. That's great. Hope, rethink training, overcoming, community global fund. Yes, the mental health, the global mental health fund, Sean, that was powerful. Got my wheels turning. We do know that there are coalitions being formed, of course, here in the US around advocacy to push for policy advocacy. Here, 2020 Mom and our partners at Maternal Mental Health Leadership Alliance just had a Hill Day last week, meeting with members of Congress. But there are also other coalitions building, including philanthropy. It's building a coalition. Maybe that global fund for mental health and maternal mental health could actually be possible. So very exciting.